So, Bismillahirrahmanirrahim. Let's discuss the shoulder musculoskeletal ultrasound report writing. I'm Professor Dr. Syed Amir Gilani from Afro-Asian Institute of Medical Sciences, Lahore. The main structure of report consists of the title, the patient identification, demographics, date, recipient or referral and the provider details, name of the individual involved in the examination, indication like the history and clinical information if provided, then is the technique and procedural description when and where required, then we mention the findings and give conclusion or impression. Before we start writing a report, we must know the medico-legal duty of care. Professional is legally accountable. It is a public document, part of the patient's medical record. Patient's consent, written or verbally, by explaining the procedure is required, and right to expect competent ultrasound practitioner. We have to provide the local guidance, standardize account for the examination. Communication with shoulder team for reference means with the referral or with the concerned surgeon or physiotherapist about findings and conclusion. The main steps for a good report are: first is relevant, that either our examination is relevant with the complaints of the patient or with the requirements of the referral physician. We have to record the technical limitations. For instance, the patient was not able to move his or her hand or arm, any restrictions in the movement or any other limitation. Then is the scrutiny, images and cross-checking with the contralateral side. The critical analysis, we have to assess the pathologies or abnormalities and relevance with the age. For instance, in older age, we can get spark positive, whereas in younger age, it will not be a normal finding. Then is the knowledge skills of the sonographer or radiologist, and further advice, whatever advice we can give to the patient, and further investigations if recommended, we can mention. We can have professional acknowledgement or communication with the referral. Any urgent communication is recorded and reported, and communication with the patient is important, and care is very important before we start and after we perform the examination. We have to take care of the patient and the comfort of the patient. In standard report includes type of examination, for example shoulder ultrasound, the clinical details, observation of the findings, then is the conclusion. Use the relevant sentences, simple plain English, avoid ultrasonographic terminologies or abbreviations so that the patient can even understand the report. Use local template and short code. The report includes normal anatomy, for example all structures examined, pathology like measurement, increase in vascularity, additional clinical information, difficulties with interpretation if there was any. We have to mention that what were the difficulties in interpreting the report. Any surgical changes, obesity or muscular systems mobility. Any difficulty in mobility must be mentioned. As a sample, we can discuss the normal appearances of the rotator cuff tendon. No evidence of tears or calcifications or any bursal thickening or effusion. If there is no tear, no calcification, no bursal thickening, no free fluid or effusion, we can write this sentence. Then we can write the long head of biceps tendon is intact and in situ. No evidence of a glenohumeral joint effusion. Unremarkable acromioclavicular joint noted. The next point is, if appropriate, the report may include the following: rotator cuff tendon have reasonable depth and texture. There is evidence of subacromial subdeltoid bursal thickening, but no more so than a symptomatic shoulder. There is good pain-free subacromial movement, or we can say there is tenderness at the acromioclavicular joint or OA joint. For tendinopathy, we can write it like this. There is a sample report. The supraspinatus tendon appears generally thickened, thinned, and tendinopathic with loss of normal fibril pattern. No tears seen. The focal tendinopathic changes are noted at the interior, middle, posterior portion of the supraspinatus tendon. So we can say there is no tear seen. Then is a sample report for calcific tendinopathy, any pathology of the tendon with calcification. We can give the measurement. For instance, it is A into B in millimeters. Intratendinous calcification or calcium deposit is calcific flag are noted within the anterior, middle, posterior aspect of the supraspinatus tendon. No tears evident. There is 6 mm densely shadowing calcific deposit within the supraspinatus tendon. There is a 6 mm non-shadowing deposit within the supraspinatus tendon likely to be soft calcific tendinopathy. There is marked calcific tendinopathy in the rotator cuff tendon. The largest area of the calcification in the supraspinatus tendon measures 15 mm in diameter and the patient is tender on scanning. We can have these options which can be mentioned depending upon the appearance of the calcification, its size, its location, etc. Then is the sample report for bursitis, how we will report it. The subacromial subdeltoid bursa contains an effusion and the wall is hyperemic on power Doppler. The patient is tended to scan here and appearances are consequent with bursitis. A sample report for long head of bicep. We can say that the long head of biceps tendon is intact but has dislocated from the bicipital groove medially and is sitting in the surface of the subscapularis tendon. The long head of biceps tendon has sublux onto the medial lip of the bicipital groove. The tendon is thickened and appears edematous. The tendon sheath is hyperemic and contains an effusion and the patient is tended to scan here. Ultrasound appearances suggest an intact sublux long head of biceps tendon with evidence of tenosynovitis, which is the inflammation of the tendon and the synovial membrane. Then comes the sample report for the tears, which are the partial thickness tears. There is a partial thickness tear of the bursal or articular surface or intrasubstance. We need to know that there are 3 types of partial tears according to the location. First is the bursal, second is articular, the third is intrasubstance, which is within the substance of the tendon. So we can say there is a partial thickness tear of the bursal or articular surface or intrasubstance depending on the location. Then of the interior aspect of the supraspinatus tendon, which measures 2 mm depending on the size in longitudinal section and 3 mm in transverse section. It means we will be scanning longitudinally and transversely, getting the both measurements of the tear. Then we can say that the supraspinatus tendon appears generally tendinopathic and there is a partial thickness which is articular or bursal surface tear within the anterior, middle or posterior portion of this tendon. And this tear measures XX millimeters into XX millimeters, or we can say A to B measurements in millimeters and affect over or under 50% of the tendon depth. So we will be measuring the depth of the tendon, then measuring it transversely, longitudinally and transversely, and mentioning the percentage of the torn area. Then comes the sample for report of partial tear thickness. There is a partial thickness tear on the articular surface of the supraspinatus tendon lying X millimeters or ABC millimeters posterior to the rotator interval. It measures XX millimeters in width, means mentioning the size of the width, and extends over or under 50% of the tendon depth. The remainder of the tendon has reasonable depth and texture. If we get full thickness tear, the sample report will be, we can say that there is a full thickness insertional tear of the supraspinatus tendon lying ABC or XX millimeters posterior to the rotator interval. The tear measures XX millimeter, mentioning the size in width, and there is XX millimeter retraction from the insertion. So we will measure the retraction, the gap. The remainder of the tendon has reasonable depth and texture. Another sample for full thickness tear, which is complete full thickness tear, is that we can mention that the supraspinatus tendon has completely ruptured and retracted. The retracted tendon end is not visualized. Cuff arthropathy noted. We can say that there is complete full thickness tear of the supraspinatus tendon with proximal retraction of, mentioning the size in millimeters from the insertion. This will be the pattern of the shoulder ultrasound report, which is normal, and a complete report will be like this: examination, ultrasound of the shoulder, date of study, for instance November 11, 2021, patient name Mr. ABC, registration number of the patient if there is any, then writing the history, for instance if it is shoulder pain, evaluate for rotator cuff abnormality. Then we will write the findings: no evidence of joint effusion, the biceps brachii long head tendon is normal without tendinosis, tear, tenosynovitis or subluxation or dislocation. It means means these are the main 5-6 points which we have to mention about the bicep long head. Then comes the supraspinatus, infraspinatus, subscapularis, and teres minor tendons are also normal. No subacromial subdeltoid bursal abnormality and no sonographic evidence of subacromial impingement with dynamic maneuvers. The posterior labrum is unremarkable. The additional focus evaluation at the site of maximum symptoms was unrevealing. Then we will say the impressions or conclusion. Unremarkable ultrasound examination of the shoulder. We can say the no rotator cuff abnormality. Now note that there are few important things. The bicep, we have to write about its appearance, fusion, tendinosis, tear, tenosynovitis, or subluxation or dislocation from the bicipital groove. Then we have to look into supraspinatus, infraspinatus, so subscapularis and teres minor 4 tendons. We have to mention about their appearance and any tear or calcification. If there is any calcification, the size of the calcified area. If there is tear, we have to give the classification according to the size and location. Then the next thing is the bursal abnormality, appearance of the wall, any fluid inside. Then by having dynamic examination, by performing abduction at the shoulder joint, we will look for any impingement, and then we look at the posterior aspect of the shoulder for posterior labrum. If everything is normal, we will give the conclusion that it is normal rotator cuff musculoskeletal ultrasound or remarkable ultrasound examination of the rotator cuff for abnormality. Then we have another example for abnormal shoulder having some pathology. Similarly, we will be mentioning examination of ultrasound of the shoulder, date of study, then patient name, registration number, and history. For instance, it is shoulder pain, evaluate for rotator cuff abnormality. The findings can be, there can be many scenarios. As I mentioned, that the involved structures are 5 tendons for impingement, bursa, labrum, etc. So these are the main things. We can also include the ligament, like the acromioclavicular ligament is important. So we can say, if we take this scenario, we can have a report like this, that there is a focal anechoic tear of the anterior distal aspect of the supraspinatus tendon measuring 1 centimeter short axis by 1.5 centimeters long axis. The anterior margin of the tear is adjacent to the rotator interval. There is no involvement of the subscapularis, infraspinatus, or rotator interval. A moderate amount of infraspinatus and supraspinatus fatty degeneration is present. There is a small joint effusion descending the biceps, brachii tendon sheath, and moderate distension of the subacromial subdeltoid bursa. No biceps brachii long head tendon abnormality and no subluxation or dislocation. Mild osteoarthritis of the subacromial subdeltoid joint, which will be evident by the osteophytes or spur formation. Additional focused evaluation at site of maximum symptoms was unrevealing. Then we will write the impression or conclusion. Focal or incomplete full thickness tear of the supraspinatus tendon with infraspinatus and supraspinatus muscle atrophy. So this is how we can write abnormal report. These are some of the references I used for this talk, and thank you very much.